So, shall we start? Giri sir, shall we start?
Hello. Yeah. Yes, you can start now.
Okay, sir.
Sir, namaskar.
Namaskar.
So, good evening, everyone. A very warm welcome to all our distinguished faculty members, delegates, and participants joining us from across the country. On behalf of the International Association for Integrated Oncology, IAIO, it's my pleasure to welcome you all to today's IAIO Expert Insight session, Gynecological Cancer. And I'm Subhashi, and I'll be your host for today's session. Before we begin, it's my privilege to introduce our esteemed program director, Dr. Bhagyalakshmi Nayak is Professor Department of Oncology, AHP GIC Cuttack. Dr. Nayak has made significant contribution in the field of oncology through her clinical expertise, academic excellence, and a commitment to improving women's cancer care. Ma'am, we are honored to have you with us today. Dr. Bhagyalakshmi joining shortly. So we will start the scientific program. So our first scientific lecture, it's my pleasure to invite Dr. Sushil Kumar Giri, Professor Oncology, Odisha University of Health Sciences, Bhubaneswar. Sir has extensive expertise in gynecologic oncology and has contributed immensely to both patient care and academics. Sir, the virtual podium is all yours.
Thank you so much. Let me share my presentation. Is it visible now?
Yes,
Yes,
sir.
sir.
So thank you so much for asking me to talk on the subject that is a very interesting subject and very complicated subject. And this is current landscapes of molecular markers of endometrial carcinoma. So yes, it is becoming a burning topic of today. So now, they are the let me they are the ladies or women, or they do develop endometrial carcinoma commonly, but not nowadays. It is becoming a little bit of this. And yes, this is the typical features of endometrial carcinoma.
Sir, sorry to interrupt, sir. So,
Yeah.
your screen slide is not visible in full screen.
So, now is it visible?
Yes,
Yeah.
yes.
Okay. So these are typical features of the women suffering from endometrial carcinoma. It was now it is becoming less and less because thin patients are also having this. So now you saw endometrial carcinoma is a disease of elderly with comorbidity, obesity, hypertension, and diabetes. They are all the commonest thing in development of endometrial carcinoma. But of late, there has been a rise in the incidence of young females, and we do not. The reason is not well known, but perhaps this is the lifestyle changes which is creating all this problem. And it is occurring if it occurs in advancing ages, it becomes more aggressive in nature. So now coming to topic proper, that is this is a molecular classification. Before that, let us see how the classification of endometrial carcinoma was evolution occurred there, and what are the gist classification that occurred. So the historical or pathogenic type of endometrial carcinoma. Traditionally, endometrial carcinoma is classified into type 1, which is estrogen-related endometrial, and type 2, non-endometrial aggressive tumors. There is definite substantial heterogeneity between type 1 and type 2. There is definite heterogeneity, and there is no clinical utility, not much there. They are only to provide conceptual framework for understanding endometrial cancer pathogenesis. The type 1 is estrogen dependent mostly, but now there is little change in it, and type 2 is non-endometrial and estrogen independent. So looking into this, let us see one case scenario. A 54 years patient presented with postmenopausal bleeding, diagnosed as endometrial carcinoma grade 1 endometrial carcinoma. So surgical staging done, and it was when the primary tumor diameter was less than 2 centimeter. It was, and pathology staging was that it was a grade 2 endometrial adenocarcinoma. So my invasion was less than 50%, no cervical stomach invasions, no LVSA. So it was stamped as low risk stage 1 A2. So because it was low risk, so no adjuvant treatment was given. But to our bad luck, she came after 9 months with vault recurrence. So what to do? So it was grade 2 endometrial adenocarcinoma, molecular staging. Then molecular staging we started. But by the time it was not that common molecular staging done, and we came out. It was just P53 abnormality was found. So it is now staged as stage 2C2 molecular P53 abnormalities. So what happened? In the first instance, we did not give any adjuvant therapy, but recurrence would have been avoided by adjuvant therapy if P53 status had been known earlier. So P53 abnormalities molecular subtype is found only in 5% of the grade 1 and grade 2 adenocarcinoma, endometrial carcinoma. So molecular status is a must in all endometrial carcinoma and should be integrated into pathology classifications and stratifications of care to prevent under and overtreatment. So this is the number one concept came out. So there is a call for improved classification of system of endometrial carcinoma, but it should be subjective, objective, reproducible, and biological informative. To classify tumors as per biotypes, to enable precise risk stratifications, to modify management decisions. So molecular risk stratification is the call of the day to identify 4 prognostic factors, that is P53 in low risk and good prognostic cases, this poorly in high risk group of endometrial carcinoma. So this is the must in all endometrial carcinoma. Mostly, so one should think in that way, so that we can prevent under and over treatment. So current molecular classification of endometrial carcinoma is a molecular landscape of endometrial carcinoma is defined by 4 distinct genotypes, genomic and prognostic subgroups established by the cancer genome atlas TCGA, shifting classification away from the purely traditional histology, that is type 1, type 2. This is almost obsolete, going to become obsolete. So what happened? TCGA has shifted it in 4 types. I'll come later on. The landmark molecular taxonomy established by the TCGA remains the foundation of contemporary practice now. The integrated molecular model guides the prognosis, risk stratifications, adjuvant therapy, and targeted treatment. So this has been incorporated into the FIGO 2023 staging system and ESCO ESP 2025 recommendations. So this is what is the molecular classification is now going up. So WHO classification, you see, WHO in 2014, then there is a change in 2020. 2020, they have put the molecular classification into classification systems. So when WHO is saying the integration of molecular parameters into standard pathology reporting by WHO 2020, it is imperative that the world is now aware of the rationale of for molecular subtypes of specific cancer of endometrial carcinoma. So what is the TCGA classification? It started in 2013. So it has got molecular subtypes, that is a pole ultramutated. It occurs 7 to 10% of cases of molecular of cancer endometrium. It is a pole exonuclease domain mutation is there. Usually it is done in high grade, mostly high grade tumors, pole mutation should be thought of. And so treatment may be deaccelerations and the prognosis is excellent. And MMR deficient is MSH. So it is around 25 to 30% cases it occurs. There is MLH1 methylations, MSH2, MSH6, PMS2 mutations. It is mostly occurs in endometrial carcinoma and immune checkpoint inhibitors. I don't enter into all this treatment facility. Dr. Sanapati will talk on this. And there is the intermediate prognosis. If copy number low, this is NSNP, a non-specific molecular profile. So it is a highest. It is highest to get it. And it's 35 to 40% it's there. What are the molecular alterations? It's CTNNB1, P10, PIK3CA, ARID1A, and KRAS. It occurs mostly in low grade endometrial carcinoma histology will be there, and chemotherapy or adjuvant therapy in high stage is there. The treatment is the prognosis is intermediate or good. And there is a copy number high. This is most important. This is the aggressive variety. This is mostly P53 abnormalities there. 20 to 25% are found in this type of cancer endometrium. There is P53 mutation is there, mostly in serious and grade 2 endometrial carcinoma. His father certified by ER status, CTN and D1 and L1 came, and his prognosis is very poor. So the TCGA 2020 initiated the molecular classification. It is expensive, but it is very expensive because everything was done in a PCR based. So it is unsuitable for wider clinical applications. To overcome these issues, a simple, inexpensive, and clinically usable molecular classification system was developed by the Promise as a proactive molecular risk classifiers for endometrial cancer. Molecular classification is mostly applicable to high-grade endometrial carcinoma, but is applied to all endometrial carcinoma. And the question comes whether it can be applied to other things, serous, clear cells, undefiled. Yes, there are few studies showed it can be applied to non-endometrial type, that is serous, clear cell, and undefiled carcinoma and uterine carcinoma can be applied, but the implication is not yet defined. So for adjuvant treatment recommendations, the molecular classification seems particularly relevant in high-grade and or high-risk endometrial carcinoma. So this is as far as OESP in 2021 recommendations. So Promise is the surrogate marker of TCGA. Promise it stands by ISC. MMR protein can be stand. P53 it is either abnormalities or wild type. But pole is detected by PCR, digital PCR, and pole EDM is surrogate marker of pole alternative group. MMR T deficient is surrogate marker of MSI hypermutated. P53 wild type or NSNP is surrogate marker of copy number low, and P53 abnormality is surrogate marker of copy number high. So now this is the very interesting scheme because all ECs should have a pole testing should done. If it is pathogenic, it is called pole EC pole mutant. If it is pole wild type or non-pathogenic, one should go for MMR testing. If MMR deficiency is the EC MMRT. If it is MMR proficient is there. So one could think of P53 mutation has to be tested. If it is mutant, it is called P53 mutant. So if it is wild type, so now we call it NNCP. If all are negative, so we call it NSP. This is how we test in the molecular substitute testing. And in NSNP, if we are positive, it is 85% are found there. And ER negative, 50% are found in the ER negative group. ER negative NSNP poor pregnant for hormone therapy still must to learn bad prognostic group. So about different molecular classification and clinical implications. So now we have some polymutation is there. Mutation in the exonuclease domain of DNA polymerase epsilon used in high-grade, low-stage disease and young women. Think of when I'm going to do conservative surgery, conservative treatment, one should think of we should do a polymutations. So one can think of doing conservative fertility conservation can be done. And they do not exhibit increased sensitivity to radiations or commonly used chemotherapy compared with the pole wild type or cell lines. It is characterized by extremely high mutational burden, dense tumor infiltration lymphocyte, often high-grade histology despite favorable outcome. So prognosis outstanding for survival is more than 95% and candidates for treatment deescalation in selected cases. Now MMR status, the microscopic instability, there is a loss of one or more MMR proteins. If there are 4, MLS1, MS2, MSS2, and MSS6, out of the 4, if one is deficient, we call this MMRT deficient. It is associated with microcyte instability and Lynch syndrome that is found in 10 to 15% of MMR deficient patients. Histology is endometrial carcinoma and mixed histology. Clinical significance responds well to immune checkpoint inhibitors and intermediate prognosis. So MMRD versus MMRT. MMRD means MMR deficient and MMR proficient. Improved survival with the adjuvant RT in MMRT groups, but not in MMR proficient cases. Post survival with chemoradiation MMRT. MMRT, they do not respond. One should not treat with chemoradiation. Only radiotherapy is sufficient. And MMRD and endometrial carcinoma benefit from addition of immunotherapy to conventional adjuvant therapy regimens. Now it is the most important, the P53 copy number 5. It is characterized by T53 mutations, extensive chromosomal instability, common in serous carcinoma, carcinosarcoma, high-grade endometrial carcinoma. Grade 3 now, we are now going for that. And features are aggressive behavior, advanced stage at presentation, usually. Prognosis is worst among all molecular groups. Patients with P53 endometrial carcinoma, improved outcome with concurrent chemoradiations with 5 years recurrent survival of 59% versus 36% with radiation alone. Any stage of PP3 nodal carcinoma with my invasion is considered high risk, and chemotherapy recommended with or without radiation. Yes, there is other school of thought that only chemotherapy will suffice in PP3 abnormal patients with my invasions. So one may or may not use radiations. So NNCP endometrial carcinoma is copinumber low, characterized by PP3 wild type. So all PP3 wild type, MMR intact or MMR proficient, all negative with variable prognosis. They are grouped under NNCP non-specific molecular profiles. Common molecular subtype found in half of the this is a common molecular profile. Subtypes found half of the endometrial carcinoma with intermediate prognosis. Most challenging molecular subtypes given the lack of predictive biomarkers. Common mutations are CTNNB1, KRAS, PIK3CA, PTEN, and ARID1A. Emerging markers are CTNNB1 mutations, L1CAM expressions, and hormone receptor status, ER and HER2. So, till further molecular refinement with NSM-EC is developed, adjuvant treatment in NSM depends on grade, stage, USL, types, and ER status. So, common ultrasound in NNCP. What are the common ultrasound we found in NNCP? There is PTEN around 60 to 80% of all NNCP. PIK3CA around 30 to 50% of all NNCP. ARID1A is 30 to 40%. KRAS is 15 to 30%. CTNNB1 is 20 to 30%. And FGFR2 is 10 to 15%. So recent development is ER positive NNCP has better prognosis. CTNNB1 mutant NNCP has increased chance of recurrences, and high grade ER negative, high grade NNCP in high grade 3 regions, and ER negative NNCP had more aggressive behavior. They are grouped under high risk now. So multiple molecular classifier is 3 to 6% of endometrial carcinoma they are found. MMRD with p53 abnormality is classified as MMRD. Whole mutation with p53 can be treated as whole mutant. Stage 1 carcinoma single classifier p53 endometrial carcinoma 5 years with difference survival is 7 to 80%, whereas MMRD plus p53 this almost the 5 year survival is 92.2%. And the pole mutant plus 53 is around 94%. So when there is pole mutant, there is survival is better. For clinical management, p53 mutations with MMRD-EC or pole mutation EC in early stage, intensified treatment is not recommended. So biology and prognostic significance of multiple classifier EC is unclear now. Till now, we are not sure what are going to happen with multiple classifiers and how they should be managed. The answer is not here with us. So now coming to us, etiology, correlation, and molecular landscape. So now what happened? If a low grade endometrial carcinoma comes, grade 1 and grade 2, the common molecular type is NNCP and MMRD. If high grade endometrial carcinoma comes, the grade 3, the common molecular type will be polymutations, MMRD, or p53 abnormalities. If serous carcinoma is there, p53 abnormality will be there. Clear cell, again, MMRD or p53 abnormality will be there. Carcinoma is almost always p53 abnormalities. And if there is unresolved carcinoma, MMRD is there, and sometimes you get a p53 also. Now coming down, key mutations in endometrial carcinoma. What are the key mutations? We see PTEN gene. PTEN, it is a tumor suppression gene, and around 40 to 80% cases are found in all endometrial carcinoma. PIK3CA, PIK3 signal is there, 25 to 40%. ARID1A, chromatin remodeling is 30 to 40%. CTNNB1 is dominant signal 2 to 30%. KRAS is MAPK pathway is between 25%. Only DNA proofreading is 7 to 10%. P53 is genome integrity 22%. HER2 and ER will be 2, or this is almost same. The growth signal is between 20%. Serious carcinoma, and FGFR2 is self-reproduction 10 to 15%. So these are all frequency we get these different molecular mutations. Get it. So now there is only that TCGA is not the only. There are many things beyond TCGA. So TCGA we have 4 that is everybody knows, only p53 and MMR. But here there are many molecular markers beyond TCGA. There HER2 new implication. It predicts response to transgenital and uterine serous carcinoma. ERPR expression predicts the endocrine therapy. L1CAM associated with the recurrence and poor survival. CTNNB1 mutation, poor prognosis in low grade NNCP tumors. ARD1 loss, potential immunotherapy biomarker is there. PI3 mTOR pathway therapeutic target under investigations. PDL1 expression is limited role compared with MMR status. Tumor mutational burden TMB is predictive for immunotherapy response. Homologous recombination deficiency is a potential future role for PARP inhibitors. So these are also to be thought of in future. Now question comes importance of molecular stratification. What are the importance? Without molecular classification, the adjuvant treatment is dependent on histological factors. Molecular classification seems particularly relevant in high-grade and high-risk carcinoma, but applied to all animal carcinoma. With addition of molecular profile into micromorphological findings, the risk stratification is modified with stage shift, for example. Now, there is every one stage can be shifted to other stage. So now, one example is a hysterectomy specimen with grade 2 endometrial carcinoma with invasion into outer half of the myometrium stage 1B. On review of the local cancer center, this tumor is considered grade 3 and therefore assigned to stage 2C. When molecular classification results became available and a pathogenic pole mutation is identified, the same patient has stage changed to stage 1AM pole mutant. That is now she becomes from stage 1B to 2C to now 1AM pole mutant because of molecular classification, and now it becomes a low risk patient. So now a patient has surgery at one institution and their pathogenic diagnosis of grade 2 endometrial carcinoma with less than 50% Maya invasions. There is no LVSA, her nodes are negative. According to the W23 figure, she is now stage 1A2 disease. The same patient goes to another institution for a second opinion, and the pathology, their diagnosed tumor is grade 3 endometrial carcinoma. Now she has stage 3C, stage 2C disease. Grade 3 means stage 2C disease. She goes elsewhere for the third opinion. This institution offers molecular testing, and a tumor is found to harbor a pole hotspot mutation. She is now stage 1A. One polymetric disease, means the low risk disease. Accordingly, one example, a patient has surgery and is diagnosed with grade 2 endometrial carcinoma with 1 millimeter of Maya invasions, no LVSA and negative nodes. The treating institution performs p53 IC but does not offer pole mutations assessment. Her tumor is deemed to p53 abnormal. She has been stage 3, stage 2C p53 mutations disease. The patient has gone to another institution that offers polymetric testing and she is found to have a pole mutation. She now has stage 1A pole mutant disease. Even if p53 is abnormal, now we can see now she's in a low risk group because only plus p53 is a low risk now. The multiple classifiers. So all this chaos now ensues. So now question comes how to manage. Management will be Dr. Sanapati will be speaking on this. I'll go in just. So endometrial carcinoma is surgical stage and pathologically examined. MIS is preferred. Hypertomy is an age indicated. So molecular factors can be determined preferably from the biopsy specimen upfront. There are reasons behind it. Because biopsy specimen is small specimen which is better preserved in the formalin. So it gives a better molecular expression than tissue which is doing the hysterectomy. So one should think about it. So surgery can be modified according to the pre-op molecular factors. For example, if it p53 abnormalities or aggressive tumor is there, aggressive staging should be done, including ompectomy may be required because it behaves like a serous carcinoma. If MSIH, Lynch syndrome or p53 abnormalities, their operant preservation should be avoided. Fertility conservative surgery should be avoided in MMRD and p53 abnormalities. So if stage 1 and stage 2 category, if a pole mutant, it is a low risk. p53 abnormality is high risk, except stage 1, A1 and 1C. NNCP grade 3 and or ER negative is high risk. So these are all in general, in summarizing. Now adjuvant treatment as per this category outline. So let us see once molecular structure is known or unknown. So if the molecular structure is now this is seen. If there is a molecular structure is not known, if it's stage 1B disease, it becomes an intermediate disease. So once treatment should be discussed by Dr. Sanapati. I'm discussing about this. If molecular structure is known, now become 1B, it was 1B. Now it has become pole mutant, it become low risk, it was intermediate risk. If it is NNCP, ER positive or MMRD, becomes intermediate risk. If NNCP ER negative is high risk, or if it becomes pole mutant, it becomes high risk. So it becomes from intermediate risk, it will become high risk, low risk, intermediate risk, all things will come up. And if it is a stage 2 C disease, means it is an aggressive tumor, and that is any myelomas. So molecular status is not known, is high risk, and adjuvant treatment as per risk factor. If it is molecular status is known, pole mutant, it becomes low risk. MMRD plus myelomas plus no cervical stromal invasions, no LBSI becomes intermediate risk. MMRD plus any AMI, any myelomas, cervical stromal invasions plus minus LBSI or plus LBSI become high intermediate risk. Now it is pole mutant or NSMP high grade or ER negative, they becomes high risk. So treatment becomes varies. Treatment varies from different from one to other, from low risk. There are treatment doctors and will take intermediate risk, high intermediate, high risk. So now it is an interesting point. One 53 pole mutant is there. Diamond is a pole mutant. Pole mutant can be one A M pole mutant. But P53 is the abnormality is there. You also take test C pole mutant. Then comes if it is a aggressive histology, if there is myo invasion is 0, there is no myo invasions, it is stage 1C. It may be NSMP or MMRD. If it is myo invasion more than 0, it is 2C NSMP or MMRD. But if it is non-aggressive histology, there is a, if the LBSI is either focal or no LBSI, that is myo invasions is 0, no myo invasions, it is stage 1A molecular profile NSMP and MMRD. If it is less than 50%, it is stage 1A to NSMP and MMRD. If it is there is low grade and unilateral ovarian cancer, it is 1A3 NSMP or MMRD. But if it is there, it becomes 2C. If it is myo invasion more than 50%, it is 1BM NSMP MMRD. If a cervical stromal invasion is there, it is stage 2A molecular profile NSMP MMRD. If there is substantial LBC is there, now it is stage 2B molecular profile NSMP MMRD. These are all in general in summarizing. So these are all the different low risk, high risk, low risk, all these things, different. What I showed summarizing this thing. And 1.1 is stage 1A1 with NSMP ER negative and P53 abnormalities. Stage 1C NSMP ER negative, P53 abnormalities, they are all uncertain risks. So there is high risk of recurrence, then low risk in 60% case of stage 1A, P53 there. So maybe included under high risk carcinoma, but not yet defined. To how to treat this patient, not yet defined. There are many centers, they say we can wait and watch, we can observe this. And if it high risk, we know high risk cases are they need adjuvant therapy, mostly concurrent chemotherapy. Once molecular factor is known, adjuvant treatment is dependent on the stage and the corresponding molecular characteristic and stage shift. So stage 1, stage 2, stage 3, stage 4, accordingly we plan out for treatment of patient. Adjuvant treatment can be initiated after molecular status and evaluations, regardless of risk stratification. So low risk, low intermediate risk, high intermediate risk, and high risk. We may avoid thinking about it. Only we should think the stage and risk and the molecular status. Accordingly, one can think of treating the patients. And they do not require adjuvant therapy. Who are they? Stage 1A1 and stage 1C endometrial carcinoma patients, irrespective of the molecular subtypes, they are because they are uncertain risk. Patients with low grade mismatch repair deficiency without LBSA and myo invasions, they do not require adjuvant treatment. Patients with low grade ER positive NSMP and endometrial carcinoma without LBSA and intrusion to cervix, they do not require adjuvant treatment. Mind it. Stage 1A1, stage 1C endometrial carcinoma, patient with low grade mismatch repair deficient MMRD without LBSA and myo invasions, patient with low grade ER positive NSMP without LBSA and intrusion to cervix, they do not require adjuvant treatment. So what are the key takeaway? Endometrial carcinoma is a complex disease characterized by substantial molecular heterogeneity and varying biomarker distributions across histology, stages and molecular subtypes. Integration of comprehensive molecular profiling into routine practice to refine prognostic stratifications and guide biomarker-driven therapies is the call of the day. 4 major TCGA or promise group, there is poly, MMRD, P53, and NSMP drive prognosis and treatment. MMRD and HER2 are established predictive biomarkers. NSMP remains the most heterogeneous subtype and is an area of active research. And we are thinking on this. Thank you very much for listening. Thank you.
Thank you, sir. Thank you for your excellent and informative presentation. Our next speaker is Professor S.N. Sanapati, President, Odisha Society of Oncology and National President, Association of Radiation Oncologists of India. So thank you for joining us. The platform is yours, sir. Over to you.
Good evening. My slides are visible.
Yes, sir, visible.
Is it running? No, I think it's not moving.
No, sir. Yes, yes, sir, moving, sir.
Okay, fine. Yeah, good evening to all of you. And thanks, Giri sir, that he has made my job easy. My topic of discussion is on update on management of endometrial cancer. As Professor Giri has highlighted, that is a topic having a lot of controversy. And in the meantime, a sea of changes that has been made in endometrial cancer. So the factors that guides that the treatment of endometrial cancer are mostly histological type, depth of myoinvasion, grade of the disease, LVSI, whether it is focal or substantial LVSI, then the lymph node metastasis, whether it's macro or micro, then the cervical stromal involvement, and most important, the two things, that the stage of the disease as well as the molecular profile. So based on this, if you see the risk factors or the recurrence rate, mostly if it is the grade 3 or the adverse histopathology, nodal status, and also P53, and also NSMP, and particularly the high, here the recurrence rate is high. So based on this, only changes that have been made, the factor that is the T staging as well as the integration of the molecular profiling, particularly what Dr. Giri also highlighted, that the molecular parameter has been also included in WHO 2020. But ultimately in 2025, ISCO, ISTO and ESP guidelines for management of patients with endometrial cancer that has come out. It is somehow confusing, but I'll try my best to highlight it in a very simple way. So what is the ultimate modalities of treatment? Either keep the patient on observation or give the radiation, either the teletherapy or the vaginal brachytherapy, or we can go for the chemotherapy with radiotherapy followed by the maintenance chemotherapy, or also we can add the immunotherapy or its combination. So these are the different options that are available with us. So what changes that have been made in figure staging 2023? If you'll see here, the stage 1A, that is the non-aggressive confined to endometrium, 1A2 non-aggressive, less than 50% or less than half of myoinvasion, and focal LVSI. Okay. And 1-3, low grade confined to the endometrium and ovary. 1B, more than 50, more than half of myoinvasion with focal LVSI here. And 1C, here, it is aggressive histopathology, but confined to polyp or endometrium. So this is the story of 1. Then if you see for the stage 2 disease, stage 2A, it is non-aggressive, confined to the cervical stroma. Stage 2B, non-aggressive, but here the substantial LVSI. And stage 2C, aggressive histopathology and any myoinvasion. And stage 3A1, it is ovary and fallopian tube involvement, 1A2, subserosa and serosal involvement. Yes. And stage 3B1, it is the vaginal involvement, and B2, it is the pelvic peritoneal involvement. Stage 3C1, it is pelvic group of lymph node, whether it is micro or macro. And stage 3C2, it is the parotid group of lymph node involvement. And stage 4A, involvement of the mucosa of bowel and bladder. 4B, abdominal peritoneum, and also 4C, it is distance metastasis. So a lot of, they have also analyzed and also included a lot of histopathological beside the anatomical aspect in this staging. Now comes, already Professor Giri has highlighted the molecular aspects, and also I can highlight here that 4 molecular aspects. We have to remember 4 incidence 6 to 13%. Then comes the MMRD, that is 16 to 29%, NSMP 40 to 65%, and P53 abnormality 4 to 35%. But most common NSMP, that is 40 to 65%, MMRD 16 to 29%, P53 around 4 to 34%, and very less, it is 6 to 13%, it's all mutated. And if you see the response of the prognostic of the biological behavior, patients are having poor mutated are best prognosis, whereas P53 is worst prognosis. So in between remains the MMRD and NSMP. So after poll, it is MMRD, then NSMP, low grade and ER positive, and subsequently the worst prognosis it is NSMP, high grade and ER negative. Here already Professor Giri has highlighted the stage migration. If in only stage, particularly stage 1 and 2, if there is P53 mutation is there, then it will be designated as stage 2 CM P53, M stands for mutated. And if it is pole in 1 and 2, then irrespective of the stage, it will be designated as 1A M pole mutated. And multiple classifiers already we have discussed. If it is pole plus MMRD, it will be taken as 4. 4 plus P53 also it is taken as 4. MMRD P53, then it will be taken as MMRD. Pole plus MMRD plus P53, it will be taken as 4. So this is the story of the molecular aspects. But these molecular aspects are, if you see here, mostly important in stage 1 and stage 2 disease, and it has less significance in stage 3 and stage 4. But however, it has a lot of impact for the decision making of the treatment. I can show you here that the first one, this is the pole mutated, that means polymerase epsilon, that is responsible for the replication and also proofreading. If pole is mutated, then what will happen? That a lot of ultra mutation, the cells that will be mutated, and also it will produce a lot of antigen. And ultimately, there is stoma is mostly infiltrated with the antigens, and also a lot of CD4C T cells will be migrated. So it is highly immunogenic, and that is responsible for the, it is a hot tumor, and for which, though it is biologically aggressive, but the outcome is better. So in the pole, we can keep the patient in 1 and 2 on observation, but if it is high risk, instead of combination, though it is in uncertainty group, however, instead of going for chemoradiation, can I do the de-escalation? That is, we can consider for the only radiotherapy. And MMRD, particularly, there, this is also highly immunogenic. And can we consider the immune check inhibitor? That is the immunotherapy. Besides chemotherapy, can I also consider for immunotherapy? Then comes that the NSMP, and NSMP is not a one type. So either mostly the estrogen receptor positive or estrogen receptor negative, or there is also role of beta catenin, and ultimately, so this is a multiple, there are 4 types. Already Dr. Giri has also highlighted. So here, this comes under the, mostly if it is low, then it is 2 types. If it is ER positive, NSMP, ER positive, then prognosis is better. NSMP, ER negative, prognosis is bad, and it also comes in high risk category. And regarding P53 here, because what happens? Normally, the cell will migrate from G1 to S phase. But it is by the CDK4/6 that propagate the cell from G1 to S phase. what happens? P53 is responsible prevention of the CDK4/6 to migrate the cell from G1 to S phase. So when the P53 will be mutated, then the cell will migrate from G1 to S phase. So if there is any mutation, so mutation is not being repaired, and the cell will propagate. So here that P53 is responsible for the HHR pathway. So that is the role of the different drugs, particularly PARP inhibitors with that of the P53. So based on this, if you see here, the mutation load, the neoantigen load is highest in pol mutated, then comes the MSI. Similarly, the CD3 cells or the total T cell load is highest in pol and MSI than the MSS. Same also CD8 T cells are. So based on this, whether it is pol mutated, MMRD, MSI, so these two are mostly the highly immunogenic and very hot tumor. The prognosis is excellent. So here, can we de-escalate the treatment or can keep the patient on observation on pol mutated and MMRD as it is highly immunogenic, there is the role of immunotherapy. So based on this, that if you see here that low risk of NSMP versus high risk of NSMP, mostly it is grade 1 and grade 2 is low and grade 3 is high risk. LVSI is negative or focal in grade 1 to in low NSMP, but it is substantial in high risk NSMP. But if you see that CTNN-P1, it's usually negative in low risk and it is positive in high risk. And LCAM, that is also negative in low risk, but it is positive in high risk. And if you see the ERPR receptor status, it is strongly positive in low risk and it is in high risk, it is weakly positive or it is lost. So based on this, the rainbow trial, which is continuing and expecting the results, that if it is P53, standard treatment is chemoradiation. But people have thought that if we can also, beside chemoradiation, if we can put them on PARP inhibitor, that is for the P53, and MMRD, as such, this is comes under the high intermediate risk. And here, can you go for the radiation? Beside that, the radiation plus PDL inhibitor, that the checkpoint inhibitors or immunotherapy. And in NSMP, as such, if it is high risk, then that means NSMP high. Can you go for chemoradiotherapy versus radiotherapy plus hormone treatment? Because here the ERPR receptor comes to the picture. And pol mutated, can you go for the no adjuvant treatment versus de-escalation? So what is the evidence that in pol mutated? So this is data from PROTECT 1 and PROTECT 2 trial. If you see here in pol mutated, the outcome with the no adjuvant treatment versus external beam radiotherapy versus vaginal brachytherapy, so there is no difference. But if in P53, we can see here the role of external brachytherapy is significant than that of the keeping the patient under no observation, keeping the patient on observation. And also NSMP, also there is significant difference. So P53 and NSMP, that comes in particularly NSMP high in high risk group. And particularly in high, if you see the data, we can see here that in pol mutated in high risk group, when they combine the CTRT versus RT, there is not much difference, but in P53, there is also significant difference. So in P53, it needs definite treatment, whether CTRT or only CT, or we can also add the immunotherapy. So now comes the MMRD. In MMRD, if you can see here, the 5 trials, that is the Energy GY 018, is comparison Pembro plus chemo versus placebo plus chemo. Ruby part 1 trial with dostarlimab, the outcome progression-free survival between dostarlimab plus chemo versus placebo plus chemo. Attend trial where the atezolizumab has been used, and Ruby part 2 also, here the niraparib has been added, and also DOE, particularly here the durvalumab has been added. So you can see here, those particularly MMRD, the PFS is definitely significant when we add the checkpoint inhibitors. The other aspect in MMFs is in proficient group, there is just marginal difference in the progression-free survival. So from this, now we have to group it. So group it means taking the two things, that is the staging plus the molecular profile. So based on this, either it is low risk, intermediate risk, high intermediate risk, and high risk. So in low risk, we can keep them on observation. Intermediate risk can consider for vaginal brachytherapy or observation, or high intermediate risk, that is external beam radiotherapy, and high risk chemoradiotherapy followed by maintenance chemotherapy, and we can go for chemotherapy as well as the immunotherapy. So these are the evidence which PROTECT 1 supports the observation, and Aztec study also. PROTECT 2, that also support vaginal brachytherapy versus observation, and the GOG 99, PROTECT 1 and 2, both combined study, that is role of external beam radiotherapy, and PROTECT 3, particularly in high risk group, that is chemoradiation followed by chemotherapy. So these are the landmark trials: PROTECT 1, observation versus pelvic RT; PROTECT 2, vaginal brachytherapy versus external beam radiotherapy; GOG 99, particularly defining the high intermediate risk group; PROTECT 3 for the chemoradiotherapy in high risk disease; GOG 258, chemotherapy versus chemoradiation; and Ruby, Energy, and Atten, that addition of the immune checkpoint inhibitors with chemotherapy. So these are the landmark trials. So now comes to define, because it's very difficult to remember that low risk, intermediate risk, high risk, and also high risk. But I have defined in a very simple way that in low risk, let us think like pole. So in pole, all the 1 and also 2. Beside that, MMRD 1A and NSMP low. So that comes under the low risk category. And here, there is no need of adjuvant treatment. So can keep the patient on observation, because here the recurrence rate are less than 8%. Now comes the intermediate risk. So what are the intermediate risks? 1B, 2C without LVSI, and also NSMP low, particularly 1B and 2A. So here the evidence says that yes, the local recurrence are in a tune of 8 to 14%. So there is role of vaginal brachytherapy. And in high intermediate risk, what are the high intermediate risks? That is 2A and particularly MMRD 2A, 2B, 2C with LVSI, or NSMP low and 2B. So here the local recurrence rate are in a tune of 15 to, sorry, the 5 years recurrence are in a tune of 15 to 24%. And here there is role of external beam radiotherapy. However, vaginal brachytherapy, those patients who underwent lymph node staging and are at PN0, then we can also de-escalate, instead of we can also consider for vaginal brachytherapy. So this is the PROTECT study, PROTECT 2. So whatever we saw, particularly that the in stage 2, that comes in high intermediate risk group. But there is also some variations. If it is 2A, cone mutated, then we can refer it to as the stage 1A. But if it is P53, refer to as stage 2C. And if it is 2B, cone mutated, refer to as 1M. And if it is DMMR, then we can consider for EBRT plus minus chemotherapy. And P53 abnormality, refer to stage 2C. NSMP, also same EBRT plus chemotherapy, because this is mostly high intermediate risk. And 2C, aggressive histology, any myoinvasion, if it is P53, refer to as stage 2C, and treatment also based on that. Now, what are the high risk group? So, high risk group, what I highlighted here in earlier slide, that high risk group, particularly two things: one, P53 and NSMP high. So what are the criteria? Particularly 1A2, 1A3, 1B, 2, stage 3, and 4A. And in these situations with NSMP high and P53, they comes under the high risk group. And here we can consider for concurrent CTRT followed by adjuvant chemotherapy. Or we can go for sequential chemotherapy and radiotherapy. But with the evidence of the immune checkpoint inhibitors, particularly if it is DMMR. But if you can see here, J3A, same pole mutated, we can consider for only EBRT. But this is a unspecified group, not yet established, but it depends upon the decision of the clinicians. If pole mutated, can you keep an observation? Instead of going for chemoradiation, we can consider for EBRT. And if it is DMMR and stage 3A, beside the chemoradiation, we can also add the immune checkpoint inhibitors. And if it is P53 mutated, as per the standard protocol, the platinum and also taxane-based chemotherapy with radiation, followed by maintenance, followed by 4 cycles of chemotherapy. We can also consider for the PARP inhibitor, what I discussed in previous slide. And if it is NSMP, then can we add also hormone therapy? So what we have considered that we have to go for CTRT followed by maintenance chemotherapy. So one shots not fit for all. So we can also individualize the treatment in case of stage 3 B1 as well as the 4A. So this is the two situations which is not yet fully established, particularly if it is stage 3 and pole mutated, 4A and pole mutated. Can I keep this patient on observation or only external beam radiotherapy? So it is the case by case, but we have to consider for de-escalation of the treatment. Similarly, another situation also, if it is 1A and if it is P53 mutated, then there also most of the people suggest that yes, can keep the patient under observation. So this is the study or evidence. The molecular classification that predicts response to radiotherapy in randomized PROTECT 1 and 2 trials. From this, from PROTECT 1 and PROTECT 2, they have found that 484 patients from PROTECT 1 and 396 patients, the molecular profile they have got, and they have randomized into 3 groups, that 249% no adjuvant therapy, and 434% external beam radiotherapy, and 197 only vaginal brachytherapy. So what is the outcome? If you can see here, if it is pole mutated, then there is no difference in outcome. This slide I have already covered earlier. Then the PROTECT 3 trial also, the same thing, just I have also covered. But question arises in high intermediate risk group. Can I give the external beam radiotherapy to all? For that, the PROTECT 4A that has been come out, and they have also stratified into 3 groups: favorable, that is pole mutated MMR, MMR wild type, and intermediate MMR mutant, and the unfavorable, that is P53 group. So they have given the external beam radiotherapy to the unfavorable one, intermediate, that vaginal brachytherapy, and favorable can for the observation. And PROTECT, the rainbow trial that is still now continuing. However, we can waiting for the reports based on the molecular evidence from the molecular profile, the image that I highlighted here. So the major question that will be answered by rainbow, that P53 abnormality, does olaparib improves recurrence-free survival? MMRD, does immunotherapy outperform the chemotherapy? NSMP, can chemotherapy safely omitted? And pole mutated, can adjuvant radiotherapy omitted completely? So this is the basic principles that how we can best manage the endometrial cancer based on staging and also molecular profiling. That's number one. Number two, based on the risk stratification, whether it is the low risk, intermediate risk, high risk, and also on classifiers. But here we have to also give the importance of the all the molecular aspects so that we can also individualize the treatment. With this, I can conclude my talk. Thank you, ladies and gentlemen.
Thank you, sir. Thank you for sharing your valuable experience and recent updates on the management of endometrial cancer. We shall now move to our first
I think
case-based.
before we go ahead with the next session, I have to be solemnly tell that I could not join in the beginning, but then I think both the talks have been extremely well appreciated. I learned so many new things today. So thank you both, Giri sir and Senapati sir, for your brilliantly curated lectures, and I think our all our participants must be enjoying and learning so much from. So I think we have a basket of actually gynae oncology today, from endometrium to cervix to ovary. So I think please sit back and relax and enjoy the upcoming panels.
Thank you, Dr. Bhatia.
Thank you, sir. Thank you, sir, so much for your time and energy. And you have taken really so much of pain to prepare those beautiful slides, sir. Thank you so much.
Thank you. Thank you. Okay. Go ahead.
Shall we start, ma'am?
Yeah, please do.
Okay, we shall now move to our first case-based panel discussion. And to moderate the session, I would like to invite the moderator, Dr. Soni Nanda, Assistant Professor, Gynecologic Oncology, AHPGIC Cuttack, and joining her are our esteemed panelists, Dr. Shruti Bhatia, Director and Senior Consultant, Gynecological Surgical Oncology, BLK Max Super Specialty Hospital, New Delhi, Dr. Ashok Padi, Associate Professor, AHPGIC Cuttack, Dr. Shweta Rai, Director, Gynec Oncology, EMS Hospital, Delhi. Dr. Mamita Nayak, Associate Professor, Department of Pathology, HPGIC Cuttack. Professor Dr. Ghanshyam Viswat, Executive Director and Consultant Medical Oncologist, Pulse Healthcare, IMS Insam Hospital, Bhubaneswar. Dr. Lucy Patnaik, Professor, Radiation Oncology, HPGIC Cuttack. Dr. Aditya Mishra, Consultant Medical Oncologist, Apollo Cancer Center, Bhubaneswar. I now request Dr. Shoni Nanda to kindly moderate the discussion. Over to you, ma'am.
Thank you. Firstly, I would like to thank IAIO and our program director, Dr. Bhagya Nayak, madam, for giving me a chance to moderate this panel. So I shall be sharing my slides. So is my slides visible? Are they visible?
Yes, ma'am.
Yeah, okay. So I'll be now directly going on to my first case. So basically, as you all know, cervical cancer remains one of the leading causes of cancer-related mortality among women worldwide. So advances in screening, vaccination, concurrent chemoradiation, surgery, and immunotherapy have significantly improved outcomes. However, 20 to 40% of the patients with locally advanced cervical cancer develop persistent or recurrent disease after a definitive treatment. And once this recurrence occurs, management becomes complex and requires individualized decision making. So the challenge today is no longer only curing the primary disease, but identifying the right salvage strategy for the right patient. So my first case is a 53 years lady, para 4 living 4, who presented to us with a history of contact bleeding, 3 episodes in the past 3 months, and occasional purulent discharge per vagina over the past 1 month. On a post speculum examination, the cervix was hypertrophied and unhealthy. On PV examination, the uterus was 12-week size, soft, and there was a barrel-shaped cervix. On PA examination, there was bilateral parameter was supple, rectal mucosa was free, and multiple punch biopsies taken revealed that the histopathology was cervicitis. Ultrasound examination done showed there was an endocervical growth of approximately 5 to 6 centimeter. So we planned her diagnostic hysteroscopy and biopsy. On a hysteroscopic examination, the endocervix was full of growth, and it is really difficult to visualize the cavity. On clinical examination, there was ballooning of the cervix with a growth of around 6 to 7 centimeter, which involved the lower uterine segment. Both the parameters were free, and clinically it was stage 1B3 disease. On a histopathology examination, it came out to be adenocarcinoma of the cervix grade 2, P16 positive, ERPR was negative, HPV 16 positive, and Vimentin was negative. when a CMRI was done, and it revealed that there was an infiltrative heterogeneous enhancing endocervical mass of approximately 7 into 5 into 4.5 centimeter with lower uterine segment involvement, and there was an enlarged necrotic right lateral pelvic node. So the diagnosis was adenocarcinoma cervix stage 3C1R. So now how will we proceed in this disease? My first question, like, should squamous cell carcinoma and adenocarcinoma be managed differently? Dr. Shweta Rai, madam, what is the opinion on this? Kindly opine.
So as such, there are no evidence to suggest that adenocarcinomas should be treated differently compared to squamous cell carcinoma. Whatever studies are available are generally a mixed bag of squamous cell carcinoma and adenocarcinoma, though we all know that squamous is more common and the adeno was a small fraction of all those studies, which went on to say that in big tumors, radiation is better than surgery. However, by biology, we understand that adenocarcinomas are generally radio-resistant tumors. They are generally chemo-resistant tumors. So, occasionally we tend to go more towards surgery in case there are large tumors, especially if we find no involved pelvic nodes, parametria free, but the tumor is as such large or just it is polypoidal, some 4-5 centimeter mass coming out of the cervix. But in this scenario, it is clear cut that it is a large mass along with pelvic node. In this case, there is no doubt that we should actually offer her chemoradiotherapy. In case she feels that there may be other options to be explored.
So many literature have come like that the adenocarcinoma is associated with poorer overall survival and disease-free survival as compared to the squamous cell carcinoma. And evidence also suggests that adenocarcinoma may be more radioresistant than squamous cell carcinoma, and it requires aggressive or different treatment approaches. However, till now, there is no standardized fundamental difference in the treatment strategy between the squamous cell carcinoma and adenocarcinoma, with both being treated based on the stage-guided protocols. That is, in the early stage, we go for surgery, and in advance, we opt for CTRT. Now, is there a role of CTRT, Dr. Lucy Patnaik, madam, in this particular case?
Yes, this particular case is ideal for concomitant chemoradiation, where cisplatinum is the drug of choice to be used concurrently on a weekly basis with external beam radiotherapy followed by brachytherapy.
Right, ma'am. So concurrent CTRT using platinum-containing chemotherapy is the treatment of choice in stage 1B3 to 4A disease. So particularly in our patient, which was an adenocarcinoma cervix with such a large growth and node positive, is there any role of NSCT followed by surgery? Dr. Shruti Bhatia, madam? What are your views on this, ma'am?
NSCT is a very good option to decrease the mass of the disease as well as for micrometastasis. So actually it is a very good thing, but so far it is not the standard of care. So ideally NSCT followed by surgery should be done only in a trial settings and not as a general protocol for treatment. So far we are not doing, although for this case it would be a very good option.
Right, madam. So there is no consensus as to whether NSCT followed by surgery improves prognosis as compared to the standard treatment. And NSCT followed by surgery is not superior to CTRT in the trials which have been conducted earlier. And so let's see what FIGO 2025 guidelines has to say on this. They have also stated that NSCT surgery is best reserved for research settings or those areas where radiotherapy is unavailable. And this is especially true in patients with very large tumors or adenocarcinoma, which have a lower response rates. So, Dr. Ashok, sir, is there any role of induction chemotherapy followed by CTRT?
Yes. Am I audible, Swani?
Yes, sir. Yes, sir. You're audible.
So that is definitely a role of induction chemotherapy as it is proved in so many trial settings. Say, if you go for GCIG interless trial, it clearly states that that is a short course of this combination chemotherapy of carboplatin with a low dose, that is area under curve 2 with paclitaxel low dose 80 milligram per meter square. If you are giving before 2 concurrent chemoradiation, definitely it has an advantage of if you see the PFS and OS, there is a difference of around 8%. That is 80% versus 72%, 5-year OS, 5-year PFS. Again, there is a overall OS advantage also in terms of around 10% more. if you're adding a induction chemotherapy along with CCRT, because these are once we are starting with this low dose of low dose of chemotherapy, definitely that will decrease the tumor burden and the micrometes. So definitely, because the concurrent CTRT will be better. So there is a definite survival advantage. But in this trial, the main problem is that the negative aspect of the trial, they have not included lower vaginal margins, lower vaginals. That is the only. But in your case, you have taken there is a pelvic node, lymph node positivity also. That's why it is 3C1R.
Yeah.
Is it na?
Yes, sir.
So one pelvic node. Radiologically, there is also one pelvic node. So I think particularly in this case, definitely if you are going for an induction chemotherapy, definitely it has a survival advantage.
Okay. Okay. So based on this
I think
interlist
Giri sir
trial,
wants to
induction.
tell something.
Yes,
Sunny,
sir.
please.
Sir, please. Yes, sir.
Sir, Giri sir, you wanted to tell something?
No, I'm not doing anything.
Okay. So shall I continue?
Yes, yes, continue.
Sir, your
Okay, sir.
hand is raised actually, so we thought you wanted to.
Oh, by chance.
Oh,
Okay.
Okay, Sunny, please. Welcome. I think welcome all the panelists. Dr. Ghanshyam sir, in spite of all his problems, he has still been able to join. Thank you so much for being there. Yeah, please go ahead, Sunny, please.
Well, I have to share my screen again.
No, we can see your screen.
See?
Yes.
I'm actually not able to see.
Yeah.
So I think in the meantime, there are some questions on the chat box. So I request the panelists who are in the panel or
So actually, somebody has raised a question that is there any limitations of this interlaced trial? Definitely, I have already mentioned that actually patients with paraortic lymph nodes involvement and lower vaginal involvement are excluded from that study interlace. So there we could not comment that whether that is adding this short course of chemotherapy in form of carboplatin and paclitaxel to just before for 1 to 6 weeks before the concurrent chemotherapy has any survival advantage or not. But I'm pretty sure if it is pelvic lymph node in locally advanced cervical cancer with pelvic lymph nodes mets also, definitely it has a survival advantage in form of both OS and PFS. They already proved. So definitely in your case, definitely one should go for the short course of chemotherapy followed by concurrent chemoradiation.
Right, sir. So now is my slides visible right now?
Yes.
Yes.
Okay. So based on the interlaced trial, induction chemotherapy followed by CTRT can be an option for stage 3 to 4A disease. So let's see what FIGO 2025 guidelines has to say on this. Only in low resource settings where access to high quality radiotherapy is constrained with a prolonged waiting time, the interlaced induction chemotherapy regimen can be considered. So now, what is the role of immune checkpoint inhibitors along with CTRT, especially in this case, where a patient is having high-risk factors such as a large size growth with node positivity? Dr. Ghanshyam, sir, so what are your views on this? Can we add immune checkpoint inhibitors with CTRT, sir?
So yes, so the keynote A18 trial where they included basically high-risk patients, which was stage 3AB and stage 4A. So that along with the standard chemoradiotherapy with a standard dose of Keytruda of 200 milligram 3 weekly. So they were given it for 2 years. So 5 doses along with CTRT and thereafter. So that has showed definitely benefit. So if you have a patient in our setting, so probably we have to go by a interlace, which is an affordable, can be covered in Ayushman. For somebody who can really have a deep pocket, so definitely for high risk population. So because we know that since 1999 we have a CTRT protocol, and still 50% of these patients won't survive beyond 5 years. So definitely, so A18 is a positive trial in this setting.
Right, sir. So according as per even the recent NCCN guidelines, they have also added the pembro with CTRT for stage 3 to 4 cervical cancer. So our patient has received CTRT and presented to us 4 months after completion of treatment with a residual disease of 4 centimeter. So now, would should we would consolidation chemotherapy post CTRT help to regress the tumor? Or if I reframe the question, is there any role of consolidation chemotherapy post CTRT in such large tumors with node positivity? And is there any evidence supporting this? Dr. Aditya, what are your views on this?
Hi, good evening. So basically, the largest phase 3 trial we have is the Outback trial, and it was a negative
Right.
trial. So the simple
Yeah.
answer is no, there is no role of consolidation chemotherapy post CTRT. So we'll rather go the interlace way or the A18 way.
Right. So as you have already mentioned, the Outback trial, which was a phase 3 trial that investigated whether adding adjuvant chemotherapy to standard CTRT improves survival for women with locally advanced cervical cancer. So though they found that there was no any survival benefit, rather it increased the toxicity. And so they concluded that standard CTRT alone should remain the primary treatment and adjuvant chemotherapy should not be administered in this setting. So now moving on to my next question, how to define and differentiate persistent disease from a recurrence? Dr. Shweta Rai, madam.
So, as such, I'm not aware of any specific criteria to define residual versus recurrent. However, any tumor which we find persisting till or coming within 6 months of completing the treatment, we generally consider it as residual, and beyond that, it is recurrent. Quite often, I mean, it is generally a protocol to evaluate the patient after completion of radiotherapy, generally at around 6 weeks. So most often, if it is residual, you will be seeing some amount of changes which appear like residual. And if that persists till 6 months, generally we call those type of things as residual. Most often that is how we define residual. And beyond that,
Yeah, ma'am, continue, ma'am. Yes, ma'am.
So, and beyond that, beyond the 6 months, especially if everything was normal before those 6 months and we are seeing new lesions after 6 months, it is considered as recurrent.
Right, right. So persistent disease, it refers to a residual tumor present within 3 to 6 months after completion of the definitive treatment. And in recurrence, it's a disease that reappears after a documented complete response, at least 6 months after the completion of CTRT. And MRI and PET-CT performed at least 3 months after the RT might help distinguish treatment-related changes from viable tumor. So what next to be done? So how do you evaluate a patient with residual disease post-CTRT? Dr. Shruti, madam?
Yeah, so as you have said, whenever a patient has received CTRT, we should wait for at least 3 months before evaluating if there is any residual disease. When patient comes to us, take a detailed history. If she's having an abnormal discharge or any bleeding is persisting, do a good pelvic examination because that will tell you a lot, especially a PR examination, because most of these cases have colpoclasis. There we cannot visualize the cervix, the vagina is stenosed, or we are not able to see. But if you do a good PVR examination, we can see how firm or hard the cervix feels, how does the parametrium feel, and if there is any nodularity, hardness, that will give us a very good idea if there is any local disease, any recurrence. Secondly, we need to do a imaging. So imaging, can we do an PET-CT? We can do an MRI. Normally, I prefer to do an MRI first because MRI gives a better view, better tissue enhancement regarding the local. And if I suspect a metastatic disease, then a PET-CT would be there. So, or sometimes
Right,
both of them. Yeah.
Yeah. So FDG PET-CT, which is done within the 3 to 6 months of completion of therapy, is best for detecting nodal and distant metastasis and planning of salvage therapy. And MRI pelvis is best for local disease extent. And both the investigations are complementary in deciding a line of management. So a PET-CT scan reports which are done in this patient, it revealed an FDG avid soft tissue lesion involving the cervix and the central uterine region, measuring approximately 4 into 3.8 to 3.5 centimeter with a SUV max of 9.4. CMRA pelvis was also done, which revealed that there was a soft tissue mass involving the cervix with extension into the central low uterine segment, measuring approximately 4 into 3.5 and 3.6 centimeter, demonstrating diffusion, restriction, and heterogeneous post-contrast enhancement, which was suspicious for cervical malignancy. And there was no definite parametrial bladder, rectal, or pelvic sidewall invasion. So next, is biopsy mandatory when a PET-CT report is showing residual disease? So should biopsy be done? And if so, why? Dr. Ashok Parisa, sir,
There are two school of thoughts here. Actually, if you just go to the FIGO Cancer Report 2025, definitely it says that you need to have a biopsy-proven residual disease actually to stamp at the residual disease prior to your treatment. But so the concern here is that if you have a narrow vagina, you are not able to take a biopsy properly. So in that case, if you are evaluating with the PET CT and you are getting a SU max of 9.4, definitely, I think there is no need of biopsy. You can straightway go for the management treatment. So,
Okay. So as sir has told,
but
yes,
ideally,
when
but one thing is very clear. One should be very clear. If you're able to protect biopsy properly, definitely we should go ahead with the
definitely,
biopsy. Then you
you
go
should
for
go with
start treatment. But in particular
yes,
this scenario where the biopsy is not possible here, then it's okay. You can rely
we
on the
can.
PET CT report and straightway go for the management.
Okay, sir. So whenever
Yes,
technically
Sony,
feasible,
Sony,
yes, sir.
yes, here also I'd like to add a sentence. Biopsy will always, stamp the disease as a recurrence instead of, putting in doubt whether it's a fibrosis or it's some
Radiation
inflammation,
induced
because
changes
SUV is 9. So biopsy will always be better.
will be better. Yes,
So we
sir.
can proceed only
So
after biopsy.
And
okay,
sometimes
ma'am.
also due to fibrosis and all this necrosis also, that is you are not able to also detect.
Difficulty taking a biopsy. Yeah. So I'll come to this in my next slide, sir. So yes, whenever technically feasible, biopsy confirmation is recommended because radiation-induced fibrosis and necrosis can mimic a recurrent disease. So, but in some patients with a suspected persistent or recurrent cervical cancer after CTRT, where imaging strongly suggests residual disease, but histopathological confirmation is not feasible due to the radiation-induced vaginal stenosis, fibrosis, or synechia, how should management be approached? Dr. Shruti, madam, what do you think? How can we approach this case
No,
if
so
biopsy is not possible?
vaginal biopsy not possible. Sometimes if we can see a distal mets, if there are some metastasis is seen somewhere else, and we can take a FNAC or a biopsy from there to prove the disease.
Guided biopsy.
Then otherwise we have to counsel the patient, and because it's a local centralized disease and we are planning to do a salvage surgery for them, then I think we need to counsel the patient that even if there is a big doubt that disease may or may not be there, but for you surgery is the option. And and again, surgeries are not simple in these cases. They are complicated surgery post radiation. So we need to
Yeah.
counsel the patient then and approach accordingly.
So in this case, I think there should be no doubt that biopsy can be done anyhow, either without imaging or with imaging. This is quite big tumor, and biopsy will be
Yeah.
done.
Yeah.
The
Yes,
This
ma'am.
doubt
is possible.
doubt of not performing biopsy comes in a remotely located tumor, which is difficult to sample even through imaging. To the small tumors, and sometimes doubtful whether it is residual or fibrosis or recurrence. So if it is that kind that we are not able to approach, quite choose to follow it after a short interval of time, like 6 weeks, to see whether it has increased in size, has become biopsiable or not. Preferred if we are planning such treatments because they are generally morbid. Treatment is generally morbid.
Okay. Okay. So, if no biopsy is feasible and delaying treatment is likely to compromise the outcomes, can we plan the salvage treatment considered on the basis of strong clinical radiological evidence after careful documentation of the rationale and informed patient consent, Dr. Aditya? Can we go for a salvage treatment
Yeah.
based
So
on only the imaging findings?
biopsy is feasible, you do a biopsy, but
If
even
it's not feasible.
it's not feasible, then also we can go for salvage treatment. Although you are not technically politically correct, but you can go ahead with salvage treatment. Again, in recurrent setting, we use bevacizumab also, and then it is post radiation. So there are chances of toxicity also because of that. So I would avoid it if and discuss with the patient and avoid it. Yeah.
Okay. So management should be individualized based on the clinical circumstances and multidisciplinary discussion. But we were lucky enough, we were able to take a biopsy from this residual disease, and the histopathology of the residual tumor came out to be residual adenocarcinoma with marked treatment effect, characterized by stromal fibrosis, herniation, necrosis, and scattered viable tumor cells. And these findings were consistent with the persistent residual cervical adenocarcinoma after CTRT. So what to do next? Dr. Lucy, madam, is re-radiation feasible for this particular patient?
No, re-radiation is an option, but not for this patient because it's only, I think, 6 months. Six
Yeah,
months
4 months,
post
4
RT.
to 5 months.
So
Yeah.
yeah, so when we think of re-radiation, at least we should maintain 1 year of disease-free interval. So
Right.
after treating the patient, there should be a gap for 1 year, Only after 1 year we can think of re-radiation, even with modern linear accelerators. But however, we can try brachytherapy in this patient. So this is a good candidate for brachytherapy. With good localization, we can achieve coverage in brachy.
Ma'am, even after
Not
just
with
after 4 to
external
5 months.
radiotherapy, no.
Okay, so re-radiation is not an option for this patient. And it's only in highly selected patients where there is only a small central recurrence, long disease-free interval, no severe prior radiation toxicity. In those cases, we can opt for this. And this refers to the re-radiation refers to the second round of radiotherapy to treat recurrence at the primary tumor site, and the appropriate selection of indications is crucial. The interval from completion of
any role for proton, Lucy? Any role for proton in this
No,
patient?
even for proton, we will always keep at least 12 months gap.
Yeah.
The only option we have here is for brachytherapy. Brachytherapy can be done in this patient.
I think Senapati sir also wants to
Our
tell.
patient has already received brachytherapy, no? So in the
Yeah, she has
total
already
CT
received that.
regime.
Sir,
Yes,
she has already
for
received
a recurrent
brachytherapy.
disease, for a recurrent
Yeah,
disease, external radiotherapy has no role in a period less than 1 year. So at least you have to maintain 1 year gap. Yes, the sir wants to say. Sir.
yeah. A few clarifications here because the eminent gynecologists are here. So in this case, I don't think that this is a lesion, 4 centimeter lesion, and there is no hindrance to take the biopsy within 6 months of the completion of treatment. Because fibrosis, vaginal fibrosis within 6 months is not an issue. Number one. Number two, with biopsy, we can also get that what is the histopathology, number one, even though there is also necrosis, fibrosis, but also can we think for any further adjuvant therapy like checkpoint inhibitors like that? That is number two. Number three, in this case, 4 centimeter lesion, and earlier also it was adenocarcinoma, and there is failure with radiotherapy. We cannot salvage with only brachytherapy. That's not at all possible. Yes, there is role of any surgery if it is feasible.
Yeah. That
Because,
time.
Yes, definitely.
because para is
I'll
not
go to
involved.
it.
Yeah.
I'll go to it in the next slides. I'll be discussing that, sir. So, as ma'am has already mentioned, the minimum, the interval from the completion of previous RT2 recurrence is a key reference, and it, at least with an interval of more than 2 years, patients will have better outcomes, and the interval should not be less than 1 year if we are going for re-radiation. So now, moving on to the next question, what is the role of salvage surgery, Dr. Ashok sir?
Yeah, definitely. Because the patient has earlier received chemo radiation and it has not responded properly. It's a kind of residual disease. And we have done a PET CT and found no disease anywhere. So thing is that first we have excluded the distant meds. We have one, so if there is no intraperitoneal or extra pelvic spread and parameters are free as per the MRI, your parameters are free. So why not to go? I think surgery is a better option. I will definitely prefer in this case to go for a
You're not audible, sir.
hysterectomy. So my point again, radiation. So sorry, am I not audible? So am I not audible?
Now it's audible, sir. Now, sir. Yes, sir.
Yeah. So the only good prognostic factors for surgery is that if there is an isolated central pelvic recurrence with no involvement of pelvic side walls, and it's a long pre-interval, and if the diameter it has mentioned in so many literatures, it should be less than 3 centimeter. But this is a case of adenocarcinoma, which is having a 5 to 7 centimeter earlier, and with radiation it is not acted properly. Then I think better is the salvage hysterectomy here. I should go for.
Yes, sir. Okay, sir. So, as sir has already mentioned, exenteration and adjuvant hysterectomy are salvage surgeries for strictly selected patients with central non-metastatic residual recurrent cervical cancer post-RT treated patients. Those are having a good performance status, and those are having a resectable disease with the possibility of achieving negative margins. And NCCN 2026 also states that adjuvant hysterectomy can be considered in patients whose tumor shows poor response or has residual disease after CTRT and ICBT, and but it only improves the pelvic control, but no overall survival benefit has been seen, and there is more of morbidity. And NCCN also states that we should be considering adjuvant hysterectomy in patients with small, persistent or recurrent cervical cancer that is less than 2 centimeter after CTRT, and those who are not having any metastasis, and larger tumors which involve the adjacent organs or are treated by pelvic exentration, which is an en bloc resection of pelvic organs followed by surgical reconstruction. So yes, since this is an adenocarcinoma although with a size of 4 centimeter, we can think of salvage surgery as the adjuvant hysterectomy. And the most important thing which should be kept in mind is the operation that is most likely to obtain negative margin should always be prioritized. So next we'll be moving on to the systemic therapy. Is there any role of bevacizumab in this particular patient, Dr. Aditya?
Yes, definitely. So bevacizumab is the first treatment, the platinums and taxanes paclicarbo. So bevacizumab showed a survival advantage of around 4 months in the GOG 240 trial. So bevacizumab is definitely the first recommendation in this patient. But yeah.
Right. So based on the findings of GOG 240 and GOG 0505, NCCN 2026 has already included paclitaxel bevacizumab as a preferred regimen for metastatic and recurrent cervical cancers. Now, is there any role of comprehensive molecular profiling, Dr. Mamita, madam?
Yes, there is a role, especially now it is very hot, the PDL1. Of course, you can go for the PDL1, MMR ISC, hot to new ISC, and along with that, the new tumor mutational burden. And this NTRK fusion. But one thing we should remember while assessing the HER2/neu that the HER2/neu in case of cervical cancer interpretation is different from that of the breast and the endometrial cancers. So while you give this type of patients for this HER2/neu interpretation, you should discuss with the pathologist that they follow the pan-tumor trial, which is the CAP protocol for reporting the cervical cancer patients in the HER2 reporting, right? And if a PDL1 you are going for, you should go for FDA approved assays. You should not go for the local assays because that may lead to misdiagnosis or the misinterpretation of the facts because they are not correct. Then as per the tumor mutational burden, you have to go for the nuclear gene sequencing. And MMR, as you know, it can be easily done by the immunohistochemistry. So that can also play a role in your treatment, I think. And for NTRK fusion also, you have to go for the molecular. So the most important part, what you have to remember is that for sending a patient for HER2, the interpretation should be according to the guidelines for this cervical cancer.
So right, ma'am. So in persistent recurrent disease, PDL1 testing, MMR testing, tumor mutation burden testing through a validated and or FDA approved assay should be considered to help guide better treatment options in the first line, second line, or subsequent therapies. So now, is there any role of circulating tumor DNA testing, madam? Mamita, madam, what are your views on this, ma'am?
Yes, when you told that you are not able to get the biopsy for the tissue analysis, in that case, I think you can go for this liquid biopsy and you can send it to where the circulating tumor cells, which say their antigens, they can help you in the deciding the treatment. In that case only, I think you can go for it. Otherwise,
right,
tissue
madam.
is a great sample.
Yeah, in the NCCN 2026, they have also added this point that if comprehensive molecular profiling by FDA approved assay, it should always be considered for better selection of systemic therapy. But if the tissue biopsy is not available and genomic profiling by a validated ctDNA assay can be considered. So now is there any, now moving on to the role of immune checkpoint inhibitors in this recurrent setting. So what is the role of pembrolizumab? Is there any role, sir, Dr. Ghansham, sir, in this case particularly?
So all
With
these
the
trials,
PDL1,
yeah, so all these trials, so maybe a persistent disease or a recurrent disease or a metastatic disease. So all these trials have all these cohort. So here in our case, which is a persistent disease, so probably in a neoadjuvant setting or with the CTRT, you are not bothered about the CPS. So here you look at the PDL1, especially CPS, if it is high, then probably so you can add the immune checkpoint inhibitors like the Keytruda. But there was another trial also with Atijo, which was a PDL1. So where they were unselected population, so they probably and both the trials showed a benefit. So either use
yes.
triplet or a quadruplet. So there was no consensus on bevacizumab as the fourth drug because the quantum of benefit with Keytruda chemotherapy and plus minus bevacizumab, but probably there was some benefit in the Atijo trial.
So with a PDL1 report in our particular patient, it showed a CPS score of 15. PDL1 was positive. We can consider adding Pembro in this patient. As per the Keynote 826 trial, Pembro when added to the platinum-based chemotherapy with or without bevacizumab, it prolonged the PFS and OS in persistent recurrent or metastatic cervical cancer. So based on this, FDA has already approved Pembro plus chemotherapy with or without bevacizumab in PD-L1 positive, persistent or recurrent or metastatic cervical cancers. Now, is there any role of atezolizumab, Dr. Aditya, in this particular patient? Sir has already mentioned that, but still then, Dr. Aditya, what do you think? Is there any role?
Yes, so basically, like Sir said, Pembro already established 826 as the first line treatment along with plus minus Bev. But in this BEAT-CC trial, they mandated bevacizumab. So bevacizumab was mandatory, it was a quadruplet. And again, they did not have any PDL1 positive subset. So irrespective of PDL1, so if you have a PDL1 negative patient also, which is rare, you can get it by using atezolizumab. But I think with using Pembro and a triplet without bevacizumab. Yeah.
Dr. Aditya, semipilimab, like one drug, semipilimab, that also has some trials going
Yes,
on,
sir.
some empowered trial
Yes, sir.
or something.
So now
It has a definite.
IO drugs, Chinese drugs are coming up, and results are better. So we are using it as such. In other subsets we are using, but in cervix we are yet to use. At least I haven't used. Dr. Ghansam can enlighten.
No, so you rightly said. So they are not approved, but so these newer PD-1 drugs are behaving differently from the standard PD-1 like Nivo and Pembro. So probably we have used in many, like we have used in head and neck cancers, and my patient has gone into a complete metabolic responses. So we are seeing responses which were not seen with these drugs, because their mechanism of action is totally different, though they belong to the same class of disease.
So, right, as already it has been discussed, according to the BEAT-CC trial, which was a phase 3 trial of recurrent, persistent, or metastatic cervical cancer patients who were randomized to chemotherapy with bevacizumab, with or without atezolizumab. So, in the post-hoc analysis, which was presented at the ISMO 2025, it demonstrated survival benefits with this atezolizumab across all PD-L1 subgroups. So addition of atezolizumab to chemotherapy with bevacizumab was added to a preferred regimen based on the BEAT-CC trial results as per the latest NCCN 2026. So now a patient has been planned for Pembro plus chemotherapy because she strictly denied for surgical management. She did not consent for any kind of surgical management. So finally, I'll be moving on to the conclusion. So today's discussion reinforces an important principle, that is, a recurrent cervical cancer is no longer managed by one specialty alone. Success depends on integrating imaging, pathology, surgery, radiation, systemic therapy, molecular diagnostics, and above all, multidisciplinary collaboration. As treatment options continue to evolve, our challenge is to select the right treatment for the right patient at the right time. So finally, in my take-home message, so always confirm the diagnosis, select the right patient, not just the right treatment. Molecular profiling is now essential. Immunotherapy has changed the treatment paradigm, and every case deserves a multidisciplinary discussion. Thank you.
Thank you so much, Sony. It was really a very interesting panel. And thank you all the panelists for making it so interesting. So I think the take-home message is really very, very crisp, that right time, right patient, and the right treatment. And it has to be multidisciplinary. You can never, ever be correct if you plan your treatment alone. So always, whenever patients come to private clinics, which actually has one doctor, it really becomes sometimes very dicey to give a subtle treatment plan. So thank you, Sony. So let's go ahead. I think there are some questions in the chat box and very excellent comments also for the panel. So welcome, Dr. Kavin. So Kavin is a consultant at Adair Cancer Institute in the Department of Gynecology. So over to you, Kavin.
Good evening, all. Firstly, I would like to thank Bhagya ma'am and IAIO for giving me this opportunity. It's my pleasure to welcome you all to this case-based panel discussion on recurrent ovarian cancer. I'm just trying to minimize it. Yeah, sorry. So with this, epithelial ovarian cancer is an aggressive malignancy with most patients presenting at an advanced stage. Primary cytoreductive surgery aiming for complete cytoreduction is cornerstone for treatment. Despite advances in treatment, recurrence remains common. Approximately 23% of relapses occur during the treatment or within 6 months of completing chemotherapy. And about 60% of the relapses occur after 6 months. Management involves systemic chemotherapy, surgery, and targeted therapy. With this background, I'll move on to my case. Mrs. X, 58-year-old woman who had stage 3 high-grade serous ovarian cancer. She received NECT 3 cycles, followed by interval cytoreduction, followed by 3 cycles of adjuvant chemotherapy with